Good morning. My name is Atul Mehta, and I am from the Cleveland Clinic in Cleveland, Ohio. It is indeed my pleasure and honor to speak at the New York State Thoracic Society Conference in honor of Dr. Trudeau. The topic of my discussion today is history of bronchoscopy, past, present, and future, connecting the dots. None of my biases are financially driven. In other words, I have no conflict of interest. I'm sure all the members of New York State Thoracic Society, which is named after Dr. Trudeau, knows that Dr. Trudeau was a tuberculosis physician. He was an expert in tuberculosis. He was a public health pioneer. He believed in disease prevention and control, and he established sanitariums as well as TB laboratories in the state of New York. Once again, it is indeed my honor to speak at this meeting, as I also started my career being a tuberculosis physician. So why the history? Why the history of bronchoscopy? Why history is so important? It has been said that the best prophet of the future is the past. Lord Byron said it many years ago. As George Santayana said, those who cannot remember the past are condemned to repeat it. As I would say, most you learned in the medical school will be invalidated by the time you retire. So you want to retain, you want to say what you learned for the future. All innovations are history forgotten, and hence I show you this picture of Lord Ganesha. Many consider Lord Ganesha as the god in Hindu mythology. But I think that this was the first ever case of solid organ transplantation in the world. As you see, Lord Ganesha has got truncal obesity. He has got telangiectasia. He has got voracious appetite. And even osteoporosis, as one of his tusks is broken. I think that he was on a high doses of steroids prior to the solid organ, after his solid organ transplantation, or this was a facial transplantation or a first ever case of xenotransplantation. And that's what I mean by all innovations are history forgotten. Prior to his solid organ transplantation or his head transplantation, as you see, he was a very robust, athletic individual developing Cushing's syndrome on high doses of steroids. Also remember that history is very forgetful. If you don't keep on repeating it, all the facts will disappear in a short period of time. And as you become older, like I am, history becomes your favorite subject. I hated history when I was in high school, but now it is my most favorite subject. Let me connect the dots related to bronchoscopy. During the early 19th century, that is the early years of bronchoscopy, it was being performed only through the rigid bronchoscopes, and the indication was foreign body removal. Day before yesterday, meaning that in the 70s, flexible bronchoscope was introduced, but it remained curiosity for many years. And I still remember the arguments between the thoracic surgeons and pulmonologists who used the flexible bronchoscope, and the surgeons were concerned that we'll create mortality as a result of using this flexible instrument. Just yesterday, flexible bronchoscopy in late 90s and early 19s became a key diagnostic tool for all airway conditions, and it was being used more frequently than the rigid bronchoscope. Today, it is not only a diagnostic tool, but it has also become a therapeutic tool. And it has also brought back, there is resurrection of the rigid bronchoscope because of the increasing use of therapeutics capabilities of the flexible bronchoscope. Maybe tomorrow it will remain the diagnostic tool, will also remain a therapeutic tool, but it also be helpful in doing research in the endobronchial tree, and technology and miniaturization will continue to increase the use of flexible bronchoscope over the rigid bronchoscope. Let me show you this tablet from the Mayan ruins as you see it. A bronchoscopist is looking into an individual's throat or his trachea, who is holding his neck. I presume he had a foreign body aspiration. He's trying to throw some light in his own airways. And this gentleman wearing a big hat and a loincloth is removing something from the patient's airway, just like Dr. Shigeto Ikeda performing rigid bronchoscopy in a patient who is awake and alert, and he is inserting his instrument exactly in a similar fashion. As I said, all innovations are history forgotten. Coming back to the reality, in year 1828, it was Dr. Babington, Benjamin Babington, he first introduced the glottoscope. And as you see the picture of the glottoscope right here, it is a candlelight delivered through the magnifying lens using the mirror in the glottic area for a proper examination. It was Horace Green in 1847. He inserted an elastic catheter through the larynx into the lower bronchi, but he was expelled from his society for doing so because it was thought to be too cavalier and a malpractice. In 1967, it was Dr. Johnson who extracted a penny impacted in a throat of a child using a laryngoscope, but this was just in the larynx and not in the endobronchial tree. The true honor of all endoscopy techniques should go to Dr. Philip Bozzini from Germany. He was an army surgeon, and he was the one who designed this endoscope for the first time. As you see it on the left side of the slide, the far left is the eyepiece of that instrument. On the right side of the instrument, you put different types of speculums, different design, depending on the organ you would like to examine. And through the center of this instrument goes the candlelight, and there is a vent to remove the smoke as well. And that was the first endoscope ever to look into the throat, look into the ears, look into the other bodily organs. His article is published in this particular document shown in the middle of the slide. Unfortunately, Dr. Bozzini, he was not a good businessman, and he died as a poor beggar on the street, but his work was eventually recognized, and his body is still preserved in one of these churches very close to Frankfurt in Germany. Manuel Garcia in 1800s, he was a music teacher, and he started examining the larynx of his pupils before he would select them. I don't know what he was looking at, but even though that was the beginning of laryngoscopy, and it was an indirect laryngoscopy started by a music teacher in this particular fashion. It was Dr. Alfred Christine. He did the first direct visualization of the vocal cords using an esophagoscope and called the technique or the instrument as otoscope, and it was in year 1895. The honor of being father of bronchoscopy goes to Dr. Gustav Killian. He started this practice in year 1897, and these are some of the early pictures of his procedure. And it was his fellow, who was a prolific writer, Dr. Kolofrath. That's what he wrote all articles for Dr. Gustav Killian, how he performed the rigid bronchoscopy. It was year 1897, as I mentioned. Dr. Killian was an ENT surgeon in Freiburg, Germany. He examined the trachea and the main bronchi of a volunteer or volunteers using a laryngoscope. And then he removed a pork bone from a right main bronchus using an esophagoscope in a farmer. In the same year, he removed 3 more foreign bodies in a similar fashion, and first time coined the term direct bronchoscopy. direct bronchoscopy, and that was the beginning of bronchoscopy in the world. It was Dr. Coolidge in 1898 from the Harvard University. He used an open urethroscope and a head mirror and reflected sunlight to remove a hard rubber cannula from the right main bronchus. And why these events are so important? Of course, they were not only that they were initial procedures, but during this era, removal of the foreign bodies required tracheostomy, and this practice and this particular procedures now prevented performing tracheostomies in patients with foreign body aspiration. The honor of being father of American bronchoesophagology goes to Dr. Cavalier Jackson. As you see it, I'm sure every hospital in this country has this Jackson speculum, as you see it, for the examination of the larynx and the upper airways. He designed it in 1913, and it is still being used. As I showed it to you in this particular inset, I just took this picture a few months ago in the operating room of the Cleveland Clinic, exactly the same instrument. Dr. Cavalier Jackson, he designed his own rigid bronchoscopes. As you see it right here, it is sitting there on this particular table. This is his lab. This is his lab or the lathe where he made or designed rigid bronchoscopes. What he did in year 1904, that he placed direct ocular mechanism to the rigid bronchoscopes. He added illumination. He also placed a suction tube, and eventually his lab or this lathe became Pilling Corporation, which made rigid bronchoscopes for years to come. Dr. Cavalier Jackson was an ENT surgeon, and he moved from Pittsburgh to Philadelphia and was instantaneously honored with professorship in 5 different universities. Besides his modification to the rigid bronchoscope, he also placed light at the distal end of the instrument, and he carried out multiple hands-on courses, as it is shown here, to train physicians to perform rigid bronchoscopy in their patients. It was Dr. Victor Negus, as I'm showing you in this particular picture, who was a British physician. That was his student. He went back to England and he designed his own bronchoscopes, which are still available today. Cavalier Jackson Jr., son of Dr. Cavalier Jackson, was also an otolaryngologist. He founded the Pan-American Association of Otolaryngology, as well as International Bronchoesophagology Society. I'm still the member of the latter society. Dr. Boyles, he added the optical telescope with forward and angle viewing to this instrument for examination of the upper lobes. Dr. Paul Hollinger, I had an honor of meeting him at an otolaryngology meeting, and he came up with the ideas and instruments for bronchoscopic photography, which we are enjoying it today. If you ever visit Mutter's Museum in Philadelphia, you should be able to see thousands of foreign bodies removed by Dr. Cavalier Jackson through his rigid bronchoscope. And it is indeed very interesting and amazing work he did in the past. This case of 3 safety pins in an infant's airways was a very amazing case, and I'm sure many of you are aware of that. All of you have heard the term Yankauer. Our anesthesiologists use this particular tool to remove secretions in patients who are under general anesthesia. It was Yankauer who performed the brachytherapy in the endobronchial tree for the first time in year 1922. It was Dr. Neil and Sanderson from Mayo Clinic, and I had honor of meeting them from Mayo Clinic. They were the first one to introduce endobronchial cryotherapy. It was Laforet who used carbon dioxide laser on vocal cords as well as upper trachea in year 1976. And it was Hooper and Jackson from Johns Hopkins. They were the individual who started endobronchial electrosurgery in 1985. There are several milestones in the history of bronchoscopy. I will not read this table, but I'll try to take you through each of these milestones as best as I can depending on the time. The honor for all flexible endoscopy techniques should go to Dr. John Tyndall. He came up with an idea of delivering light into the deeper parts of the body through fiber optic bundles. And this is how, by placing a cladding around the glass fiber, you can change the direction of the light, which is referred as Tyndall effect. As you see it here, this is used to deliver light in the deeper bodily structures. Otherwise, it would not have been possible. So his work is extremely important for the endoscopic examination. And as you can see here, we can deliver illumination to the endoscope, to the endobronchial tree or the GI tract through these fiber optic bundles. And today, these fiber optic bundles are 10 times thinner than human hair, increasing the resolution of the images, as well as increasing the illumination in the endobronchial tree. I will not take you in the details how it is being made. It is very obvious and very simple, but it is extremely helpful. This is also, I would like to state, is that the future of bronchoscopy lies in the GI tract of the patient. Whatever gastroenterologists do today, we do it 10 years later. As you see it here in this particular picture, in year 1957, it was Dr. Hershkowitz from University of Michigan developed the first gastrofibroscope, and he's looking into the GI tract of this particular patient under local anesthesia. And exactly 10 years later, in year 1968, it was Dr. Shigeto Ikeda. He was a thoracic surgeon from the Tokyo National Cancer Institute in Japan, introduced the first flexible fiber optic bronchoscope, the version of which we use today. In 1970, the first commercial bronchoscope was introduced by Olympus Corporation. Dr. Don Zavala from University of Iowa was the first one to perform flexible bronchoscopy in United States. Flexible fiber optic bronchoscope was switched to video bronchoscope based on computer technology in late 80s. And this is the evolution of bronchoscope from year 1968 to year 2022, as you see it here. The picture depicts the first ever flexible bronchoscope made by Dr. Shigeto Ikeda and Machida Corporation, which is still preserved in a museum in the Olympus Museum in Tokyo. And now all of us are using the latest version, that is video bronchoscopes, for our endobronchial examination. With the miniaturization of the charge coupled device or CCD chip, as it is shown here, the bronchoscopes have become thinner and thinner in its diameter, with as bigger working channel as possible. The size of the bronchoscope, for example, the ultrasound bronchoscopes about 7 millimeter in diameter, while ultra-thin bronchoscope could be as thin as 3 millimeter in diameter with a 1 millimeter working channel, as it is shown here. Along with the improvement in the diameter, the flexibility of the instrument has also improved, and so has the resolution of the images what we gather. The circular image is, of course, granular in nature, and it is because of the fiber optic nature of the bronchoscope, while the square image is that of the video bronchoscope with very high resolution. And all of you know that now we have sonogram structure at the tip of the bronchoscope, giving us examination also of the mediastinal and hilar lymph node for their sampling. Let's switch gears and talk about some of the techniques. Transbronchoscopic lung biopsy, that is the proper term, versus transbronchial biopsy. That probably has nothing to do with flexible bronchoscope in terms of the history. It was Dr. Howard Anderson from Mayo Clinic. He performed the first transbronchial biopsy through a rigid bronchoscope using a rigid forceps. He carried out this procedure in almost 450 patients, made diagnosis in several of these patients. Yes, he did have 11% complication rate of pneumothorax, but that is the beginning of transbronchial biopsy. When the flexible bronchoscope came into picture, the flexible version of the tools as well as the technique was established. Many of you probably still perform conventional transbronchial needle aspiration, and its roots go as back as 1949. It was Dr. Eduardo Schipati from Argentina who was the first one to perform conventional transbronchial needle aspiration using a rigid bronchoscope and esophageal varices needle, putting his needle into the carina and sampling the lymph nodes. And his first article was in Spanish language. It did not get good exposure, but when he published its translation in English a few years later, it instantaneously got exposure and people got interested in that. And based on this, Dr. Kopan Wang, then from Johns Hopkins Medical Institute or Johns Hopkins University, came up with his flexible version. Based on Schipati and Ono's concept, Wang designed a needle for its application through a flexible bronchoscope, and he made cytology needles as well as histology needles to sample mediastinal pathologies, peribronchial lesions, as well as peripheral lesions, and he improved the diagnostic yield of flexible bronchoscopy by 25% when it came to small cell cancer and almost 20% for the peripheral lesions, and reduce the need for mediastinoscopy in this particular fashion. Actually, his name today has become a verb. When we want to do conventional TBNA, we say, let's wang it. And all the credit goes to Dr. Kopan Wang. Now, putting everything together, the indication for flexible bronchoscopies were changing over the period of time from just removing the foreign bodies. Now we were using flexible bronchoscope to diagnose peripheral lung lesions. And it was Dr. Paul Kawale from Henry Ford Hospital in Detroit was the first time to show usefulness or limitation of flexible bronchoscopy. And he clearly showed that if the peripheral lung lesion is in peripheral 1/3 of the lung and less than 2 centimeters in diameter versus if it is more than 2 centimeters in diameter, the diagnostic yield of flexible bronchoscopy was 28% versus 64%. And this particular challenge continues even today when it comes to peripheral lung lesions, and I will take you through that briefly. To improve the diagnostic yield of flexible bronchoscopy, it was Dr. Hunter and Hanrath. They were the first one to show the role of radial probe ultrasound in the endobronchial tree, but it was Dr. Heinrich Becker who popularized this particular tool, not only to improve the diagnostic yield for the peripheral lesion, but also to sample mediastinal lymph nodes, which is being carried out every day today. Probably this particular event, this particular article was the biggest milestone in the history of interventional pulmonology or flexible bronchoscopy. In year 2011, it was shown that lung cancer screening could reduce lung cancer mortality by 20%, which led to widespread adoption of lung cancer screening programs. And that's what made us diagnose more and more pulmonary nodules. There are about 10 million people in this country who are eligible for lung cancer screening. Maybe we have captured half of them. And out of this 5 million individuals, 10% of these individuals have actionable nodules, making it about 500,000 nodules that need to be evaluated. And the main reason behind that is if we diagnose lung cancer in stage 1 phase, the 5-year survival could be as much as 92%. And that has made industry as well as interventional pulmonologists very much interested in diagnosing these peripheral lung lesions. And therefore, there is an establishment of advanced diagnostic bronchoscopy. This is slightly different than therapeutic bronchoscopy. This is just diagnostic bronchoscopy, which is of 2 kinds. And what I would refer to them as guided bronchoscopy versus navigational bronchoscopy, or route-directed bronchoscopies versus route-finding bronchoscopies. Some tools show you the direction where to go to biopsy the lymph node, while some tools and techniques hold your hand and take you to those lesions. Chest X-ray, CT scan, fluoroscopy, radial probe ultrasound, they are considered as route-directed procedures or route-directing procedures. They show you the direction where to go, while electromagnetic navigation, virtual bronchoscopic navigation, augmented fluoroscopy, robotic bronchoscopy actually take you to the lesion. These are the route or route finding procedures. Let's briefly talk about electromagnetic navigation, which is like a GPS system for the airway, which was introduced in year 2006. It was Dr. Steve Solomon, who was a radiology resident at Johns Hopkins at that time. He first came up with the concept of electromagnetic navigation. He was studying the liver lesions and he was studying the cardiac lesions. He was doing the studies on animal model with Dr. Kopan Wang, my friend and my colleague. For some reason, he stopped his research, but it was Dr. Yehuda Schwartz from Tel Aviv in Israel. He further studied this particular tool, came up with the human application, and that's where it started its application in increasing or improving the diagnostic yield of flexible bronchoscopy for peripheral lung lesion. Many of the institutions around the world are today using electromagnetic navigation to improve the diagnostic yield. And as I'm showing you here, with the help of this tool, you can diagnose lesions, way peripheral lesions, less than centimeter in size, benign conditions such as histoplasmosis or the lesions which are hiding behind the sternum or very close to the mediastinum using electromagnetic navigation. Similarly, one can use virtual bronchoscopic navigation where the CT information, extremely high resolution CT scan, drawing the path using the airways anatomy, take you to the peripheral lesion. So this is an example of virtual bronchoscopic navigation. The bronchoscopist is using an ultra-thin bronchoscope, as you see it here. Through that ultra-thin bronchoscope goes a peripheral ultrasound probe confirming the presence of the peripheral nodule, and then biopsying this lesion to make the diagnosis of bronchogenic carcinoma. So multiple modalities are put together once again to diagnose peripheral lung lesion in the safest fashion. And that is what is happening today in terms of flexible bronchoscopy. I already showed you Dr. Paul Cavalle's yield, which was between 28 to 64%. Today, no matter what instrument you use, you can choose the instrument of your choice or your expertise, which could be virtual bronchoscopy, electromagnetic navigation, guided sheath, ultra-thin bronchoscope, radial probe ultrasound, or all put together in combination. The diagnostic yield of flexible bronchoscopy for the peripheral lung lesion has improved to about 73%, as it is shown in this particular slide. My mentor, once again, Dr. Kopan Wang, says, what's the difference if the cat is black or white, as long as it catches the mites? So you can select the tool of your preference. Now we are getting into further advanced stage of advanced diagnostic bronchoscopy, and the newer tool is augmented fluoroscopy, where you are using live fluoroscopy on the platform of electromagnetic navigation, once again to increase the diagnostic yield of flexible bronchoscopy for the peripheral lesion. And we have already entered the robotic era for bronchoscopy. There are two different platforms, ion platforms, which uses shape detection technology, while a Monarch platform that is also based on electromagnetic navigation. And both of these tools take you to the peripheral lung lesions. When you use the robotic bronchoscopy, of course, you increase the reach of your instrument, as it is shown in this particular slide. It also gives you, as you see it here, you can go to the way peripheral part of the airways in a precise fashion with the robotic bronchoscope. This is 6th, 7th, 8th, 9th generation bronchos. You are going in there and biopsying, as you can see here, and this is guided by the robot, and you are going in that particular direction where you suspect the lesion is. So it is improving the reach for the bronchoscopist in this particular fashion. Then not only this, that you are arriving way periphery of the lesion, you can also arrive there and you can visualize. This is the robotic sheath for the bronchoscope. As you see it here, the light is being delivered and you can actually see the lesion. And you are looking at the peripheral lung lesion in this particular fashion. And then there is a tremendous control. There is a precision. You can even hit the bull's eye right here. It is an eagle's eye, but it is that precise to sample the sample the peripheral lesion. And this is what the robotic bronchoscopy is about. Yes, it is a very expensive tool, just like one of your cars. This is my Yugo. Some of you may have G55 wagon, or some of you may have a robotic car like Tesla. And it is extremely expensive. The answer still remains to be derived, that what is the incremental value of spending this much amount of money going after the robotic bronchoscopy, which has got very expensive disposable tools or devices associated with that. In my personal opinion, simple things done well, they might be good enough if you pay attention to the expenses. And I also strongly believe that you do have to be a good bronchoscopist to be an interventionalist. These fancy tools do not automatically make you an interventional pulmonologist. This is the latest information on the newer tools available to you to diagnose peripheral lesions. Arriving at the lesion not always necessarily mean the diagnostic yield. The success is you arrive there, but your sampling may not be perfect. As you see it here, electromagnetic navigation, Dr. Geck's data, you arrive at the lesion 97% of the time, but your diagnostic yield is only 70%. With the radial probe EBUS, you can arrive at the lesion at 95% rate with the diagnostic yield of 68%. The newer information, the latest information on robotic bronchoscopy and its comparison is still pending. I talked to you about diagnostic bronchoscopy. Let me shift my gears and talk to you a little bit about staging bronchoscopy. In honor of bringing out medical mediastinoscopy goes to a surgeon named Kazuhiro Yasufuku, then from Chiba University in Japan. Now he is in Toronto. He was the first one to show the effectiveness of convex probe endobronchial ultrasound in staging of lung cancer, as well as diagnosing mediastinal and hilar lymphadenopathy. All of you know about it. I'm not going to go in the details of that, but now the medical mediastinoscopy, sampling the mediastinal and hilar lymph node with the EBUS bronchoscope, has got sensitivity of 93% and specificity of 100%, almost replacing surgical mediastinoscopy. Endobronchial ultrasound as well as esophageal ultrasound have been found to be a complementary tools, and if you have skills, you can use them together. This tool is also very helpful in CT and PET negative studies, studying the mediastinum. Tool is also helpful in neoadjuvant therapy and restaging the patients with bronchogenic carcinoma. It is helpful in benign conditions such as sarcoidosis, mediastinal cyst, quasi-central lesions, which are not seen in the airways, but very close to the airways. Dr. Francisco Almeida has shown it very clearly that convex probe ultrasound can increase the diagnosis of quasi-central lesions. And Dr. Cecilia from my own institution, he routinely performs endovascular transvascular needle aspiration of the lesions, which can only be accessed through the blood vessel, as it is shown right here. So these are the things interventional pulmonologists do today. Let me shift the gears again, and now let me talk to you about therapeutic bronchoscopy. The father of interventional pulmonology, the honor goes to Dr. Jean-Francois Dumas from Marseille, France. He first reported the use of Nd:YAG laser in the airways in year 1983. He designed newer types of rigid bronchoscopes, especially for endobronchial lesions. He also designed silicon stents and stent insertion instruments. He taught his biggest virtue was not being a fine endoscopist, a very skillful endoscopist. He taught the world interventional pulmonology unconditionally. Everybody would go to his place and learn rigid bronchoscopy and interventional pulmonology. Unfortunately, he expired suddenly about a couple of years ago. These are his endobronchial stents he designed for the airway problems, and these are some of the instruments designed and named after him for interventional pulmonology. He clearly showed that if you use multimodality approach to the patients with central airway obstruction, if carried out properly, you can improve the survival of the patient with terminal lung cancer. Once again, let me switch the gears and let briefly talk to you about lung transplantation. If there was no flexible bronchoscope, there would be no lung transplantation. These patients require frequent bronchoscopies to diagnose acute cellular rejection, chronic rejection, and occasionally antibody-mediated rejection, as well as diagnose and manage airway complications. So if there was no flexible bronchoscopy, there would be no lung transplantation. And let me show you this particular incident right here. Single lung transplantation patient, 3 weeks after his surgery, developed 70% dehiscence of his anastomosis. As you see it here on the right side, the left picture, this is right anastomosis. You're actually looking into his mediastinum, and I could see his pulmonary artery anastomosis. If there was no interventional pulmonology, this patient would have died that particular day. Self-expanding metallic stent cause exuberant granulation tissue, and therefore they are not indicated for benign conditions in the airway, except that for airway dehiscence. As you see it here, the patient who would have died that particular night, he was alive 5 years later after the management of his dehiscence with self-expanding metallic stent, which was kept in only temporarily in this particular setting. And this was also a major milestone in the management of airway complication in patients with lung transplantation. We are also treating the patients with COPD or emphysema by endobronchial volume reduction. As you see it right here, FEV1 of the emphysema patient could be improved, and this improvement may remain sustained for up to 3 years after the endobronchial volume reduction, as very clearly shown in this particular slide. I'm sorry, not able to show you the good X-ray picture to show the coils in place in this emphysema patient. If you place valves, it looks something like this in the endobronchial tree. And it has also been shown that in properly selected patients, if the patients develop atelectasis following the valve placement, their survival is better. If patients have a complete fissure versus incomplete fissure, the patients with complete fissure or lack of collateral ventilations, they also fare better in terms of survival after endobronchial volume reduction. There is some data to suggest that. So interventional pulmonologist improves the survival of patients with emphysema. You can also treat the prolonged air leak from BP fistulas, once again using such valves, and it has been clearly shown in the past. Now we are also treating bronchial asthma with the flexible bronchoscope, and the credit goes to Dr. Gerard Cox from Canada. He clearly showed that this technique in selected patients with severe persistent asthma who are on inhaled corticosteroids and LABA between certain age group, who are non-smoker and have smoking history of less than 60%. and have FEV1 around 60%, they would do much better. If they have persistent symptom and bronchospasm, you can treat them with bronchoplasty to palliate the bronchial asthma. When I was a pulmonary fellow, you can use only rigid bronchoscope to remove the foreign bodies. Today, as you see it here, more than 90% of endobronchial foreign bodies are removed with the flexible scope by a pulmonologist in the outpatient department under conscious sedation in most instances. And now we are combining even electromagnetic navigation to find the location of the foreign body, such as this very small foreign body, which in the past would have required thoracotomy to remove this particular foreign body. This could be removed with the help of flexible bronchoscope using electromagnetic navigation guidance, as it is shown here. At this moment, let me take a pause and ask the audience a question. I'm sure most of you know the answer. What is the largest foreign body a pulmonologist has ever removed from the endobronchial tree? For the sake of time, I will not dwell on this question very long. With my utmost respect, a thoracic surgeon. And I'm sure you will agree with me. Why do I say that? A removal of a foreign body, mediastinal staging of non-small cell lung cancer, lung volume reduction surgery, management of prolonged air leak from BP fistula, anastomotic dehiscence, concentric web-like stenosis no longer remain exclusive to the domain of thoracic surgeon. This could all be carried out by an interventional pulmonology. Flexible bronchoscopy is the most commonly performed diagnostic procedure by a pulmonologist today. And in my opinion, there is no single pulmonary ailment a flexible bronchoscope can't either diagnose, cure, or palliate. Along with the change in the technique and the instrument, our bronchoscopy suites have also changed. That is, on the left was my bronchoscopy suite in 1981. Only one nurse, maybe one fellow, and one bronchoscopist. It was 10 by 10 room. Of course, it was leaded so that I can use a fluoroscope in this particular room. There is only one light source and nothing else. Today, my partner, Dr. Gilday, who is in charge of the bronchoscopy, he needs 16 monitors, as you see it in this particular picture here, to do one bronchoscopy, and he has got 16 hands, 2 bronchoscopists, 2 nurses, 2 anesthesiologists, and 2 cytopathologists all work together to carry out one bronchoscopy, and that is the scene today. Today, interventional pulmonology, it is a well-established subspecialty. There are more than 50 programs in the country. There are IP board examination. There are national and international organizations such as World Association, American Association, European Association, Indian Association for Bronchology and Interventional Pulmonology. There are national and international seminars. Journal of Bronchology and Interventional Pulmonology, which was established in 1994, which has been indexed. It is in PubMed and has got impact factor of 2.45. I think it is very respectable for a very new journal in that respect. And we are now publishing guidelines and consensus related to interventional pulmonology. The credit of making this organization or this subspecialty a formal specialty should go to Dr. Uday Prakash from Mayo Clinic, who was the first president of American Association for Bronchology and Interventional Pulmonology. Last 5 minutes, talking about the future of bronchoscopy. The best way to predict the future is to create it, as Abraham Lincoln said, and the things which are on the horizon are quite a few: cryobiopsy, cryospray, more guidelines for endobronchial volume reduction, bioabsorbable and 3D printing stents, stem cell therapy, confocal bronchoscopy, so on and so forth. Yes, we have learned a lot from the recent pandemic. We are using more and more disposable bronchoscope, and I think that practice will continue and it would grow wherever applicable, that we use disposable scopes to prevent spread of infection, which is indeed a true danger from a bronchoscopy. If you do not clean your instruments properly, we have our cleaning area extremely close to our bronchoscopy suite so that you don't have to transport dirty bronchoscope to a long distance. As I mentioned to you, 3D stents, Bioabsorbable stent may be the wave of the future, that they would serve their purpose and then they disintegrate without leaving any complications. We are already looking into the alveoli. Maybe this confocal bronchoscopy or microscopy would help. Confocal fluorescent microscopy may help us diagnose certain conditions without doing biopsies to reduce the complications. There are some interventionalists, they actually perforate the bronchus to go after the peripheral lung lesion, which cannot be biopsied otherwise, but time will tell the effectiveness and safety of such techniques. There is a wave towards diagnosing, staging, and treating peripheral lesion at one time, one-stop shopping. That's what they talk about, is you diagnose, you stage, and you treat the peripheral lesions at the same time. And for that particular reason, you may be using endobronchial microwaves. The mechanism of cell kill is same as electrosurgery or radiofrequency ablation, but that effect is not dependent on the fluid content of the tissue like other thermal procedures. The microwave also penetrates all biological tissues, and therefore there is more effective kill of the tumor cell, and maybe that would be helpful in treating stage 1 bronchogenic carcinoma, just like SBRT, what we are carrying out today. There are probes available which can go through the working channel of the bronchoscope to be inserted into the peripheral lesion. Of course, it remains a matter of research at the present time. Maybe we will be using tissue engineering in the patients with tracheobronchomalacia or patients with excessive dynamic airway collapse, or we might be using stem cell therapy to treat some of the BP fistulas which we encounter in some patients. Few will have a greatness to change the history, but each of us can change a small portion of the events, and in total of all those acts will be written the history of generation. And that is absolutely true. What Mr. Robert Kennedy said many years ago, it could very well be applied to interventional pulmonology. And the last few slides, connecting the dots, which I was telling you about, and I'm sure all of you know Steve Jobs, who said that you cannot connect the dots connecting forward, you can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future. You have to trust in something, your gut, destiny, life, karma, whatever. This approach has never let me down, and it has made all the difference in my life, and hope that it makes all the difference in your practice. This is my last slide. I always use this slide. I call it my editorial comments. Yes, you are an interventional pulmonologist with lots of big armamentarium at your hand, lots of techniques and tools. But because it could be done, that does not mean it should be done. It is not a sport. You just don't do it for the numbers. You just don't do it to maintain your skills. A good bronchoscopist is the one who knows when not to perform a bronchoscopy. I also strongly believe that reducing healthcare cost is a civic responsibility. Our presidents or our politicians cannot do anything about it. You have to do it yourself. One has to be larger than his or her abilities. When to use this technique is the bigger thing than how to use these techniques. There is nothing more certain than the sun and the moon in the sky that we all are going to be patient one day. So you want to treat everybody the way you want to be treated. And in my strongest opinion, whatever is safe, whatever is simple, and what is cost-effective scheme, that shall survive, and everything what I have talked about. I always want you to be a champion for your patients, not for the industry, not for the procedure, but be the champion for your patients. And as Andrew Schomel mentioned many, many years ago, primum non nocere, please first do no harm. Thank you very much, and I appreciate your attention for the last 45 minutes. Thank you.